Dear audience, let me present my PhD topic, which is New Insight in Malnutrition Prevention in Gastrointestinal Cancer. My name is Bettina Budai. I'm a dietitian and a second-year PhD student. My vision is that nutrition is a cornerstone in the multimodal care of all cancer patients, and my mission is to carry out scientific activity to bring innovation in the nutrition therapy of cancer. To achieve my vision, I have two specific goals. In the first project, we investigated the risk factors for malnutrition in patients with gastrointestinal cancer. The prevalence of malnutrition in gastrointestinal cancer is up to 30 to 90%, varies between cancer stages and cancer site. It has been estimated that up to 20% of patients die due to the malnutrition rather than due to the tumor itself. A lot of different factors can contribute to its development, like poor nutritional intake, involuntary weight loss, fatigue, or pain. These symptoms are strongly related to the inflammatory markers or the upregulated immune response. Inflammation can be worsened by the pro-inflammatory cytokines produced by the tumor itself, like TNF-alpha or interleukin-6, disrupting the metabolisms of fats, carbohydrates, and proteins throughout the body. For example, in the muscle, the anabolic and catabolic imbalance leads to muscle wasting, decreasing muscle mass and muscle strength, and increasing the fatigue. In the liver, the acute phase protein production is increasing, repressing drug clearance, and raising the risk of anti-cancer treatment toxicity. Worldwide malnutrition is still underestimated by physicians, making it difficult to identify those patients who are at high risk. So our aim was to evaluate those risk factors that can increase the risk for malnutrition in gastrointestinal cancer. We asked the question, what can be those risk factors? And we hypothesized that we can determine some clinical and biological factors of it. After the systematic selection, we identified almost 400 eligible articles. To make our result more easy to interpret, we categorized our outcomes into 5 major categories according to clinically relevant meanings, like population or tumor characteristics, laboratory parameters, the comorbidities, or the administered anti-cancer treatment. The malnutrition was assessed by different screening tools. Risk assessment tools, like symptom or etiological-based assessment tool, measured malnutrition according involuntary weight loss, low BMI, or decreased food intake. In the biochemistry-based assessment tools, measured malnutrition according laboratory parameters, like serum albumin level or total lymphocyte count. In 2018, the GLIM criteria were established for the diagnosis of malnutrition, requiring one phenotypic and one etiological criteria. We also included those articles that measure cachexia as an outcome, although there is no clear consensus regarding the definition of it. In this first aggregated forest plot, you can see the association between population characteristics and malnutrition risk. In the first column, you can see the exposure, like age above 60 or age above 65. In the second column, you can see the measurement tool that was used to assess malnutrition, and in the third column, the different cancer types. We can see that age above 65 means a higher odds for malnutrition, regardless of cancer types. Here you can see that females tend to have a higher odds for malnutrition risk, except in hepatobiliary pancreatic cancer. For example, in fatal papilla tumor, there is almost 60% higher odds for malnutrition risk in case of males compared to females. Or in pancreatic cancer, there is 40% higher odds for cachexia in case of males compared to females. Here you can see the association of biological parameters with risk of malnutrition. I would like to highlight the result of CRP level. Elevated CRP can be seen in cachexia or at the diagnosis of malnutrition, but in our analysis, already the risk of malnutrition was almost 3 times higher by elevated CRP level. It has been estimated that some certain tumor features can play a crucial role in malnutrition risk. For example, there is 20% higher odds for malnutrition in case of colon tumor compared to rectum one. Moreover, the likelihood of malnutrition is 60% higher in case of right-sided colon tumor compared to left-sided one. In conclusion, we could find out that inflammation plays a crucial role not only in cachexia or at the diagnosis of malnutrition, but already at risk of malnutrition. Till that time, there is no clear suggestion which malnutrition screening tool shall be used in certain clinical scenario. With our data, we could make some further steps for a personalized approach of malnutrition screening. Further study is needed to find out how the pro-inflammatory cytokines affect the nutritional status. In particular, malnutrition can be prevented or postponed by reduction of the inflammation and promotes the quality of life, the better quality of life, and the better treatment response. The strengths of our meta-analysis that we have a transparent methodology. We could examine a large patients number with 170,000 patients. We could determine specific cancer-specific risk factors as well. Of course, we had to face some limitations. Most of the studies were retrospective studies and the heterogeneity because of the different cancer stages and the variety of screening tools. The manuscript has been submitted in the journal Advances in Nutrition this month. In the second project, I plan to investigate the effect of immune nutrition in gastrointestinal cancer patients. Surgical resection is the primary curative treatment for most solid malignancies. The prevalence of malnutrition in surgery-related patients is approximately 60%. These patients are more likely to suffer from malnutrition due to the insufficient nutritional intake because of anorexia, diarrhea, or intestinal obstruction. Together with the surgery-related impaired immune response, malnutrition accounts for most of the postoperative complications, like infection, anastomotic leakage, delayed wound healing, or increased length of hospital stay. Immune nutrition is defined as enteral nutrition supplemented with a combination of arginine, glutamine, nucleotides, or omega-3 fatty acids. These substrates have been found out to positively modulate the post-surgical immune response and the inflammation as well. So our aim is to evaluate the efficacy of this immune nutrition in gastrointestinal cancer. We are asking the question, what is the efficacy of immune nutrition in GI cancer patients? And according to the PICO framework, the population is going to be patients with GI cancer, the intervention is immune nutrition, and the primary outcome is mortality and morbidity. The date of the search was on 22nd of March this year, and after the systematic selection, we identified 143 eligible articles. Currently, we are working at the data extraction parallelly with the citation chasing. In summary, I would like to highlight that in our first project, we could determine some cancer-specific risk factors in patients with gastrointestinal cancer. And in the second project, we plan to investigate the effect of immune nutrition in the same cancer population. I would like to thank you for my supervisors, for my SMS and TDQ students to contribute to my work in this PhD program. And here you can see the different conferences where I had the opportunity to present my work. Thank you for your attention with this quote. Impossible only means that you haven't found a solution yet.
Thank you. Again, a great presentation. Can we go back to your, I'm interested in male and female. This is not sexism, but male and female differences, that yes. You had a graph on that. So the reason behind this could be quite complex, of course. Not only the cancer. So how do you think about this?
Thank you for the question. Of course, in this case, we cannot draw a real conclusion from this table. The reason behind it that females only tends to have a higher odds, that, for example, in general, females have a lower skeletal muscle mass. And in an older age, the estrogen level, for example, is decreasing. That has an effect of maintaining the skeletal muscle on this body composition. And of course, in older age, there is a natural changing of the distribution of the skeletal muscle and the body fat mass as well. So that can be the reason for the females have quite higher odds for this.
Yeah, of course, I mean, we will not give the final words on this, but this is an interesting observation. Anyway.
Hi, wonderful presentation as always. I was just wondering, you said that there's no clear consensus on how is defined cachexia. So how, in your included studies, was there a type of a definition that was the most predominantly used, or and which one do you like the most, actually? Which one do you think it's most accurate?
Thank you very much. During the selection, we faced to this situation that the cachexia was defined in very different way, and to avoid the selection bias, we decided to include all of the articles that just talk about the cachexia as well. In most of the cases, the articles used the Fearon criteria. It was established in 2011, and it contains 3 components. The one is about that the involuntary body weight loss was more than 5%, or the involuntary body weight loss was more than 2%, plus the BMI is lower than 20. And there is another aspect that can be very interesting, that in most of the malnutrition risk, it is not an aspect, the lower skeletal muscle, the sarcopenia. It was also mentioned in this Fearon criteria. I think this is one of my. I think this is one of that we can use in general nowadays. But in the implication of research, I presented that it really needs a consensus. Then in the general medicine field, then we can talk about the same thing when we mention cachexia.
Congratulations, Betty. It's also connected to the question, like you presented, you have cachexia, GLIM criteria, symptom-based, biochemistry-based. So how could you handle all these different tools? And maybe for the practice, do you have some best tool that we can use, or what's your preference based on these results? Thank you.
Thank you. So here I presented how we categorize them. So in most of the cases, the risk assessment tool in general in clinical practice is used by the symptom or etiological based one like MAST or NRS 2002. But it's also can differ between the biochemistry-based assessment tool that is only take into account the laboratory parameters. There is a suggestion that it's better to see both of them, but till that time there is no nutritional risk assessment that consider both of the laboratory parameters and the symptoms as well. And also the GLIM criteria was the first step to solve this problem. But in the current literature, there are some critics according this, because the etiological criteria is about the disease. And they just put some certain disease that can, that in this case can decline the nutritional status, or the CRP level can be elevated. But of course, we can consider the chronic diseases as well, like dementia, or like this, that also can lead to impaired nutritional status. Thank you.
Congratulations to a very nice presentation. I very much like your second topic, so I would like to ask a question about it. And especially in gastroenterology, we use more and more the therapies like immune checkpoint inhibitors, etc. So, and I would be really interested if the immunotherapy could have a more beneficial effect in this population. Are you planning to do subgroup your population based of the chemotherapy or immune checkpoint inhibitors, or whatever regimes they will patients have?
Thank you very much. It's a very good aspect, because this immune nutrition can be effective, because of course it has an effect on the immune status, and of course we should handle this situation when they, through the intervention, the medical intervention, they receive some support to improve the immune system. So yes, we will consider it when we see the whole data extraction table, what kind of therapy they are receiving. At this time, I can say that most of the patients are surgical patients, so they're receiving this immune nutrition post-operatively, or pre-operatively, or even post-operatively as well. But not all of the patients get some chemotherapy or something like this, so it's a good idea to make subgroups according this.
So thank you for the presentation. And regarding to your second project, will you analyze like the enteral and the parenteral immunonutritions, and what supplements are? So could you tell me more about this formulation?
Yes, thank you. The definition what is used in the literature is speak about enteral form of the immune therapy. And if I see the eligible articles, most of them using this form. And in this case, the combinations are there, so the glutamine, arginine, and omega-3 fatty acids. In some cases, they combined with parenteral nutrition as well, or they just see some articles reflect about parenteral nutrition with omega-3 fatty acids as immune nutrition. So I think we are going to implement these kind of results into the systematic review part of our meta-analysis.
I'm interested in your second project. In your PICO slide, your primary outcome was mortality.
Yes.
Do you think this is the strongest primary outcome you could evaluate in this question? Maybe I would be more interested in nutritional status, like changes in body weight or muscle mass or BMI. What do you think?
Thank you for the question. I think in our, according to the data, this can be the hardest outcome, because most of the studies report the mortality in the two groups, like receiving immune nutrition or don't. We are also curious about this changing of immune nutritional status, but at this point, I can mention that maybe the changes was not so seeable, because they only receiving this therapy only preoperatively 3 days or 5 days. So this is not enough time to have a change in the body composition. So of course, I think it has a better input on the body composition, but I think the data will not present this.
All right, thank you.
Thank you.
Very interesting talk, interesting topic. Coming back to your future studies, keep it on the last slide, was fine. What do you think about including sarcopenia as a parameter in your study for the future?
Thank you for the question. So according to the guidelines of European Nutritional Society, sarcopenia is a little bit differs from malnutrition, and that's why I didn't want to combine these two, but it's a very good aspect to measure sarcopenia in the future, more likely in cancer patients, because there are some new studies that, for example, the indicated chemotherapy is more likely to calculate it according to skeletal muscle mass and not the body weight, because it can be a different because of the body composition. Of course, this is it has to have the departments, so facilities that give the opportunity to measure the body composition. So, for example, a BIA measurement is very good to it, but also in clinical studies they are using CT imaging as well. According to the CT image, the the low vertebra of the third low vertebra can give a proportion of the skeletal muscle of the whole body. So they are very good. And in the daily practice, I can say that it is using the CT imaging in cancer patients. So they can use this information in the treatment.
You're talking about GI tract cancer.
Yes.
And your aim is to investigate GI tract cancer. So, but for me, tumor is not a tumor, so it's different. If you have a bile cancer with cholestasis and you have a colon cancer, it's different. So I think if there's an effect by malnutrition, maybe it's easier to see the effect by concentrating on subpopulation, on a special type of cancers. What's your idea about this?
Thank you. Yes, we try to make it with subgroup analysis. So that's why I presented these tables, where I also in the third column you can see the specific cancer types, and for each cancer type there is a result. Of course, I think when we concentrate only for one tumor, then maybe we can see the associations and the confounders a little bit more deeper than in this case when we just put the whole GI tract cancer. This was our first aim to investigate it, but according to the result, maybe we can put some interesting information and making the further analysis concentrate only one.
So I'm interested as a surgeon. So if we feed ourselves, so it's not only for us. We have 3 or 4 kilograms of bacteria also eating our structures. Mm-hmm. So do you think it's a good idea to include also data on the microbiome you have in your studies in the future? Because I think it has an effect on nutrition.
I think this would be very, very interesting, because there are some, or in my daily clinical practice, I can see that the tolerance of some nutritional therapies very differ from patients to patients. And of course, we go through the question if he has lactose intolerance and so on, but what can be the reason to the intolerance of the nutritional therapy? And maybe this is one of them, or that microbiota can change because of the therapy as well, because of the chemotherapy, for example, or surgery can also influence the microbiome.
Very interesting topic, and I think nutritional therapy is a key element of pre-procedural at least. Do you have any data or any idea how long nutritional therapy before a procedure has some clinically meaningful outcome improvement, which is the shortest duration of the therapy? Do we have any data? Do you want to
yes,
investigate this?
So I can say that in most of the cases, 1 month is needed minimum to have an improvement in the nutritional status, because just to weight 1 kilogram, weight gain 1 kilogram, it's needed to have plus 7,000 kilocalories to eat. So it's not a very easy thing to do in only in a few days or in a few weeks. And also there is a time that is needed to see how the patients accept the nutritional therapy or not, because it's one point that we recommend it, but this is another thing that at home the patient eat this or not.
If I can have one more question, somewhat related to this. I mean, that was long ago when I was dealing with pancreatic cancer, but I did actually. We had a European network, and I remember that one of the basic problems related to this was that when you feed the patient, you also feed the cancer. Mm-hmm. So therefore, probably you need some kind of selective treatment. Actually, this is somewhat to your second studies too. But you have to be careful with this kind of feeding, because at a certain point, I mean, the cancer takes all the energy away. So in the meanwhile, that you have to deal with that too.
Thank you. Yes, I think the solution can be that the timing of the therapy, so the nutritional therapy. If it is the best when we administer the therapy not only at the diagnosis, but maybe that when we have a conscious that there will be some problem, that there will be some other in the imaging, because when we are in the late phase, the inflammation is so high that then can be called it cachexia, that we cannot, if it's feeding the patient, there is nothing, because they cannot build up with muscles the proteins.
So this is not that easy, as we see. More questions? Any questions?
Maybe two quick questions. Thank you for your nice talk. So could you please go to the slide when you show us the flow chart of the selection procedure? Yeah, here. So here we can see this Cohen's kappa value. So could you please tell us what is that and how one can interpret that number?
Yes, thank you. So that means that so this selection has to make two independent people, and this Cohen's kappa, when we calculate it, then if it's it's above 0.8, that we can say that we make the same decision during the selection, and we shouldn't have to make it again. Of course, it has to have a great selection protocol to make it, but that's why I visualized it there, that it was 0.88, so we could do further the selection.
Thank you. And my last question is, you mentioned that you are supervising 4 TDK students. That's quite a number. Congratulations. Could you please tell us something about that? Are they working, I mean, the students on the same topics that you have presented here, or on something different? Or how does it work?
So most of the TDK students are medical students or dietitian students. So in the second project, I am working together with one dietitian student who is going to write his thesis about this topic as well. So I think so we are on the same field in this case, but also the medical students could help me a lot in some aspect of the medical field, for example, in the cancer and so on.